everyone. We are Group M, and for today we will be discussing about benign cough and exertional headache. A 59-year-old male patient was referred to the neurological clinic of the University of Athens because of recurrent headache episodes for the last 5 years. The following are the listed initial and later episodes of the patient. For the initial episodes, recurrent headache with throbbing quality, localized temporally, triggered during physical exercise, and pain is severe enough to interfere with his daily functioning. For the later episodes, the patient described it as explosive headaches lasting for about 5 minutes, occurred in association with coughing and Valsalva maneuver. For the general findings, patient was alert and oriented. Extremities involved: tendon reflexes, brisk, plantar responses, flexor bilaterally, muscle tone, normal. The neurological and sensory exam were also normal. Complete laboratory tests including blood chemistry, hemoglobin electrophoresis, serology, thyroid hormones were within normal range. Headache also occurred in association with Valsalva maneuver. Brain CT scan and craniocervical magnetic resonance imaging with contrast medium revealed no abnormalities. Opening cerebrospinal fluid pressure was 17 centimeters H2O without presence of white or red cells. Levels of protein and glucose concentrations were found to be 19 milligrams per DL and 65 milligrams per DL respectively. Chest X-ray was also normal. Moreover, magnetic resonance venography revealed normal appearing cerebral vessels.
In assessing the patient's case, these steps are followed. First, we ask, is it an acute onset or a chronic daily headache? In cases of the chronic daily headaches, the next essential step is to diagnose any secondary headache and treat the problem. However, upon exclusion of any exogenous case of headache, the primary causes are taken into consideration. With the patient's chief complaint of recurrent headache episodes for the last 5 years, the patient has been experiencing a chronic near-daily headache, which he described as throbbing quality, severe enough to interfere with his daily functioning. Head pain after bending, lifting, or coughing can be due to cardiac cephalgia, idiopathic intracranial hypertension, Chiari malformation, brain tumor, infection, low CSF volume, venous thrombosis, posterior fossa mass, inflammation, and dehydration. Let's take a closer look at the patient's case. The head pain was not associated with any vomiting, nausea, photophobia, phonophobia. Neurological examinations were unremarkable. Cerebrospinal fluid testing, brain CT and craniocervical magnetic resonance imaging with contrast medium revealed no abnormalities. Chest X-ray was also normal. Moreover, MRV revealed normal appearing cerebral vessels. Now taking into account the primary causes of headache, the following are ruled out. Although the tension and cluster types of headache both are localized temporally, this can be ruled out because in tension type headache, it's useful clinical approach to diagnose TTH in patients whose headaches are completely without accompanying features such as nausea, vomiting, photophobia, phonophobia, throbbing, and aggravation of movement. Cluster headache. A core feature of CH or cluster headache is periodicity. At least one of the daily attacks of pain recurs about the same hour each for a duration of a cluster bout. For the migraine, the diagnostic criteria for migraine, nausea or vomiting, photophobia or phonophobia, should be fulfilled. These stated primary causes of headache are ruled out. Among the secondary causes of headache, the following are ruled out. One-sided severe oppressive headache radiating to the jaw, which is a sign of cardiac cephalgia, is not present in our case. Among the secondary headache, absence of nausea and vomiting makes posterior fossa mass an unlikely diagnosis. Blurry vision, nausea, vomiting, neck stiffness, which are signs of idiopathic intracranial hypertension, is not present in our case. Normal neurological exam excludes Chiari malformation type 1 as it is associated with neck pain, unsteady gait, poor fine motor skills, numbness, tingling of the hands and feet, dizziness, difficulty swallowing, sometimes accompanied by gagging, choking, vomiting, and speech problems such as hoarseness of voice. The same is true with brain tumor, as it reveals normal brain CT and craniocervical MRI. MR in combination with MRV is the single most sensitive diagnostic test for cerebral venous thrombosis. Thrombus on MRV is seen as loss of high flow signal from the sinus. However, in this case, the MRV test results are normal, which lead us into ruling out venous thrombosis as a secondary cause of headache. Furthermore, with the unremarkable diagnostic test, headache due to low CSF volume and dehydration is also excluded. The normal range of opening pressure in CSF analysis is 6 to 25 cm H2O in adults. In our case, the patient's CSF opening pressure is about 17 cm H2O, which falls in the normal range without presence of white or red cells. Complete laboratory tests including blood chemistry, hemoglobin, electrophoresis, serology, thyroid hormones were also within normal range. Hence, infection, inflammation, and dehydration are unlikely diagnoses. Thus, absence exogenous causes of headache is established. Since all of the etiologies are ruled out, leaving us with the exclusion of all these etiologies that may be present with the syndrome, primary exertion headache in the former attacks and primary cough headache in the recent ones are consistent with each diagnostic criteria.
Primary cough headache. There is generalized headache that begins suddenly and lasts for seconds or several minutes, sometimes up to a few hours. It's precipitated by coughing and can include sneezing, straining, laughing, or stooping. For primary exertion headache, it has features resembling both cough headache and migraine. It may be precipitated by any form of exercise and has a pulsatile quality of migraine. The diagnostic criteria for primary cough headache. First is, there should be at least 2 headache episodes fulfilling criteria P and D. Second, it's brought on by and occurring only in association with coughing, straining, and other Valsalva maneuver. And it has a sudden onset also. And it lasts between 1 second and 2 hours, and it's not better accounted for by another ICHT3 diagnosis. On the other hand, for primary exercise headache, we have at least 2 headache episodes fulfilling criteria B and C. It's brought on by and occurring only during or after strenuous physical exercise. It lasts for less than 48 hours, and it's not better accounted for by another ICHD3 diagnosis. Primary cough headache is a rare condition. The lifetime prevalence of primary cough headache is estimated to be 1%. One study of 975 subjects from the Danish National Central Person Registry, 1% of the general population was found to have primary exertional headache according to the IHS diagnostic criteria. The average of onset is 40. Primary cough headache is a generalized headache. It begins suddenly and lasts for seconds to few hours. It has a sharp and stabbing characteristic and is precipitated by coughing. It is preventable by avoiding coughing or other precipitating events including sneezing, straining, laughing, or stooping. For the primary exercise headache, on the other hand, it has features resembling both cough headache and migraine. It may be precipitated by any form of exercise. The pain lasts for less than 48 hours, is bilateral and often throbbing at onset. The duration tends to be shorter in adolescents than in older adults. The primary exercise headache can be prevented by avoiding excessive exertion, particularly in hot weather or at high altitude. For the management, how do we manage the case? For primary cough headache, we give indomethacin 25 to 50 milligrams twice daily. Other medications to be given are propranolol, acetazolamide, naproxen, ergonovin, IV, dihydroergotamine, and phenelzine. We also have therapeutic lumbar puncture. For primary exertional headache, there should be avoidance to excessive exercise and triggering activities. We can also give indomethacin 35 to 150 milligrams once daily to be taken orally. Other medications, same as PCH. And there is also therapeutic lumbar puncture. The pathogenesis of both primary exertional headache and primary cough headache still remains unclear. However, several studies have proposed that Valsalva-like maneuvers might be the common underlying mechanism. The Valsalva maneuver is a commonly used technique in weightlifting or powerlifting. In doing this, the lifter closes his throat, so this keeps air from escaping the lungs, which forcefully contracts the muscles of the abdomen and ribcage, causing an increase of intrathoracic and intra-abdominal pressure, creating a stable trunk which helps them lift heavier loads. This then impedes venous return flow to the right atrium by compressing the vena cava, and thus there is increased central venous pressure manifested as headache. So, since the epidural venous plexus and jugular venous system do not have valves, intracranial venous pressure is increased with an immediate rise in intracranial pressure. Also, The frequent Valsalva-like maneuver of our patient might have led to incompetent IJV valves. This incompetent internal jugular valve leads to a transient retrograde venous flow and increased intracranial pressure, leading to exertional headache. In addition to the transient increased intracranial pressure, crowdedness of the posterior fossa and CSF hypervolemia have also been postulated to be potential causes of primary cough headache. Some studies have proposed that impaired myogenic cerebrovascular autoregulation might be the central mechanism for EH, whereby EH might be caused by an aberrant vasodilation during or following exercise. And lastly, it's also possible that some receptors in venous vessels are hypersensitive to intracranial pressure alteration. That basically sums up our presentation. Thank you very much for your kind attention.